In this last section, we're going to briefly hit on other skin conditions. So there are a ton of them. I mean, dermatology is a medical specialty. Are we going to know all of that? No, we're just going to briefly touch on a few of them. So three main categories of skin conditions: non-communicable. So that includes chronic inflammatory conditions like psoriasis, genetic disorders. So that includes well, scleroderma, they're not really sure if it's genetic, but genetic disorders and autoimmune diseases. Communicable conditions include bacterial, viral, fungal, and parasitic, which we've already talked about. And associated conditions might be skin manifestations of systemic diseases. So a lot of systemic diseases have skin manifestations. And then we will also talk about skin cancer, which is a non-communicable condition. So we need to think about the considerations of wound healing, infection control, patient safety and comfort, treatment modifications that are needed for skin conditions, and when do we refer, indications for referral. So just as a general skin symptom, pruritus is itching, and it's a lot of times it's associated with allergic responses or chemical irritation, like insect bites cause chemical irritation, or infestations by parasites, ick. The mechanism of itching isn't totally understood. So there's some release of histamine in a hypersensitivity response that can cause itching. But that's not the only thing that causes itching. The problem with itching is you might break the skin barrier, and now opportunistic pathogens can get in there and cause infection. And so infection can be caused or spread by scratching. Scarring is, of course, when the tissue's healing and it's not regenerating, but it's being replaced. Sometimes people get what are called keloid scars, which are large raised scars. It's just genetic predisposition. Some people just form bigger scars than others. It's not related to the wound condition, but a keloid scar can extend beyond the original wound. So some people get these nice little, even with surgical incisions, nice little healed scars, and other people get these big, thick, wide scars. Hypertrophic scars, that's what the picture is here. They're raised red or brown, and they're due to excessive collagen formation. So some of it is genetics, like you're just good at building scar tissue, and some of it is mechanical tension on the wound. It usually stays within the wound boundaries, but they're raised. Factors that increase the risk of scarring: larger and deeper wounds will scar more. Healing by secondary or tertiary intention, where you have a big open wound where the edges aren't closely approximated. Wounds on surfaces subject to wear and tear. Complications like infection or ischemia, or mechanical tension during healing. When you have the mechanical tension, the body's like, I gotta hold it together. Let's make more scar tissue. So you don't really want that. So these are some key dermatological conditions that you might see, and often as secondary conditions to what you're really treating. So atopic dermatitis, also known as eczema, primarily in infants and children on the cheeks, arms, and legs, and it appears red, dry, and itchy. It can be associated with asthma and hay fever. Contact dermatitis is caused by allergens like latex or antibiotics. The appearance is like a blistering with an intense itch, and the treatment is to avoid the allergen. So ask your people before you give them a TheraBand, make sure you ask them if they're allergic to latex, and give them the latex-free one if they are. So check those latex allergies. Rosacea is common in middle-aged adults, females more than males. It's redness on the face, cheeks, and nose, and sometimes with visible vessels or pustules. Sun can trigger it, temperature changes, and stress. So this is eczema is the most atopic dermatitis is the most common form of eczema. So you get that chronic, dry, itchy skin. A lot of times with little kids on the cheeks, arms, and legs. Often occurs with asthma and hay fever. Usually there's some over-the-counter moisturizing creams, there's some topical steroids during flares, and antibiotics if infection is present. Infection is usually caused by itching. We want to avoid any harsh soaps or chemicals and use hypoallergenic products. Look for open wounds, gentle tissue handling, and environmental modification. So they don't really know what causes atopic dermatitis, but there is likely a genetic component. It's hypothesized. It's a chronic condition that requires ongoing management. So usually adults who have eczema know how to manage it because they've had it their whole lives. Contact allergic dermatitis. Common triggers are antibiotics, um, latex, poison ivy or poison oak, nickel, like people are allergic to metals that have a high nickel content, and fragrances can cause that. So it's a hypersensitivity reaction. It's a type 4 hypersensitivity reaction, which involves sensitized T cells. You get some skin blistering, intense itching. It's usually localized to the contact area. So in this photo, you can tell that the person had a reaction to probably the latex adhesive of a Band-Aid. Um, so the treatment is to avoid the allergen, like try to avoid it. Um, Calamine lotion, oatmeal baths, sometimes topical steroids, antibiotics if infected. So be aware of latex allergies. Most healthcare settings now use non-latex gloves, they use nitrile gloves. There are some equipment, like sometimes walkers that come with kind of rubberized handles have latex in them, or canes that have those little rubberized handles. So be aware of that. And then resistance bands and that sort of thing. So urticaria is hives. It's a type 1 hypersensitivity. Usually, like food allergies can cause this. You get these hard raised red erythematous lesions, and they're itchy. So they're usually found on the skin. They might be scattered all over the body. Sometimes you get it in the pharyngeal mucosa, and it can cause an airway restriction. So that can be pretty serious. Psoriasis is an autoimmune condition where T cells attack skin cells and you get overproduction of skin cells, which causes these plaques, these psoriasis plaques. And you have a genetic predisposition to it. The plaques can be either red to purple or they can be white and silvery, like the photograph here. So common locations are elbows, knees, scalp, and back. Sometimes there's nail involvement. Triggers can be stress, infections, skin injury, smoking and alcohol can contribute. Certain medications can contribute, and weather changes. So when you have psoriasis, you have an increased risk of diabetes, cardiovascular disease, and arthritis. 30% of people with psoriasis develop psoriatic arthritis. So the treatment, usually it's treated with topical moistures, topical steroids, sometimes UV light therapy. I think going to Hawaii would be a good treatment. Vitamin D cream and sometimes immunosuppressants. The new medications that you hear about if you watch television and see medication ads, they're usually those methotrexate immunosuppressants. The other recommended treatments for psoriasis are lifestyle modifications. Quit smoking, don't drink alcohol, manage your weight, manage your stress, infection prevention. So when we have someone with psoriasis, remember it's non-communicable, but you want to do gentle skin handling, avoiding trauma to affected areas. We can help teach people stress management techniques, exercise modifications, and we want to monitor for joint involvement because 30% of people with psoriasis develop psoriatic arthritis. You get this what they call sausage-like swelling in the finger and toes, and so you want to monitor joint mobility and function. Scleroderma is a systemic sclerosis. Sclerosis means hardening. There's a localized type and a systemic type. The localized type involves the skin only, face, hands, and feet. The systemic involves the skin and internal organs. It's idiopathic. It the clinical features includes thick, hard, inflexible skin. It affects the muscles, weakness and wasting, severe itching, and ulcerations, particularly on the hands. So you want to work on gentle range of motion, skin protection, temperature precautions. Sometimes heat can be helpful for range of motion, depending on the person. You want to monitor for infection, as you do with everybody, and help people with functional adaptations if needed. So we're going to talk a little bit about different types of skin tumors. Keratoses, they're considered tumors, but they're benign lesions that are usually associated with either aging or skin damage. So seborrheic keratoses are a proliferation of basal cells. That's why they're considered a tumor, because they're more cells growing. There's an oval elevation that may be smooth or rough. So that top photograph is a seborrheic keratosis. Actinic keratoses are on skin exposed to ultraviolet radiation, common on fair-skinned persons, and the lesions appear as pigmented, scaly patches. So they are benign. That's all we got to know. I don't know if that's all we got to know, but the warning signs of skin cancer can be a sore that doesn't heal, a change in the shape, size, color, or texture of a lesion, like a mole, especially in an expanding irregular circumference or surface. New moles that weren't there before, or odd-shaped lesions that develop, or a skin lesion that bleeds repeatedly, oozes fluid, or itches. So sometimes you'll go to the dermatologist and you'll get an overall skin check. And the idea is they want to get a baseline so they know if you have new moles or if you have lesions that change. So to reduce the risk of skin cancer, you should reduce sun exposure at midday and in the early afternoon. Not always easy, but when you can't, you cover up with clothing, remain in the shade, wear broad-brimmed hat to protect your face and neck, apply sunscreen or sunblock, and protect infants and children from exposure or sun damage to the skin, because sun damage to the skin can be cumulative over your lifetime. And so if you protect early, that's all good. So the most common kind of skin tumor is a squamous cell carcinoma. It's usually a painless malignant tumor of the epidermis, most commonly found on exposed areas of the skin, but also in the oral cavity. So when you go in for your regular dental checkup, they usually check for this sort of thing. Face, neck, and base of tongue are common areas for squamous cell carcinomas. There's an excellent prognosis when the lesion is removed within a reasonable amount of time. The invasive type arises from a pre-malignant condition. So you want to get the lesion removed before it starts to invade other tissues. So malignant melanoma is a highly metastatic form of skin cancer. It develops in melanocytes, which are the cells that create melanin, and usually from a nevus or a mole. They often appear as a multicolored lesion with an irregular border that grows quickly, changes in shape, color, size, or texture, and may bleed. So the treatment is surgical removal and radiation plus chemotherapy, because it easily metastasizes or spreads to other areas of the body. So the ABCDE of melanoma is you should suspect any nevus that changes in appearance, border, color, diameter, or if the lesion is evolving in some way. Something's going different with it. So then get in ASAP. Kaposi sarcoma is a form of skin cancer that occurs in people with immunodeficiencies, like AIDS or any other kind of immunodeficiency. It may affect the viscera as well as the skin. And the malignant cells arise from the endothelium and small blood vessels. So you get these purplish macules that are non-pruritic and non-painful, and lesions develop rapidly over the upper body. So it's treated with a combination of radiation, chemotherapy, surgery, and biological therapy like immunotherapy. For the priorities for assessment, you want to look at the location and distribution of lesions and symmetry. You want to like note dermatomal patterns, the lesion characteristics, size, appearance, if there's any drainage or odor. Odor always means infection, and pus always means infection. Pain, itching, and systemic signs. The functional impact, skin lesions can affect ADLs. They can limit your ADLs and they can cause pain and script your life through those. If you have an infectious disease with the skin disorder with active lesions, that might affect patient activities because you don't want to go swimming with your infectious skin disorder. If you're working in aquatic therapy, you should be able to tell the difference between an infectious disorder and a non-infectious disorder so you don't get people into the pool with the infectious ones. So, when you're treating someone either for that wound or as a consequence of something else, you want to avoid direct contact with skin lesions, use barrier protection appropriately, gloves, gowns, modify positioning and techniques, consider alternative locations if you're doing TheraBand things, maybe if they have a wound on their hand, you're gonna maybe do something else. Gentle approach for painful conditions. So you want to document a detailed description of the lesion, any changes from previous visits, photographs are nice. Infection control measures used, the patient response to treatment, and you want to communicate with the supervising PT as to what's going on with the wound. Red flags for immediate medical attention, shingles near the eye because there's a risk of vision loss. Systemic signs like fever, chills, malaise, pus, so secondary bacterial infections, increased redness, pus, and warmth, rapidly spreading lesions, severe uncontrolled pain, neurological symptoms like weakness, numbness, or altered sensation, and immunocompromised patients with new lesions because they're more at risk. So we want to document and observe skin changes. We want to note any new lesions or infections. We want to report all that to the supervising PT and monitor wound healing progress. You want to modify treatment based on skin condition, consider the infection control needs, modify equipments and techniques based on skin conditions, patient comfort and safety first. So if you're going to refer someone with a new or worsening lesion, signs of infection, suspicious skin changes, or patient concerns or questions. So as a PTA, you can play a crucial role in patient safety, infection control, and early recognition of skin conditions that may impact treatment outcomes. So you might be the first person that sees it and you get them referred appropriately. So that's pretty important.